All right. I'm just going to keep going because last time we ran out of time while we were waiting for other people to join us. So people will hop back on here as they come in. If you have a prolapsed cord, remember that means that the baby's not going to get any oxygen, and so you can't deliver that. So that's a surgical emergency. So you're going to flip the mom over. You're going to put her in the knee chest position, and then you're going to use your sterile hand to apply manual pressure to the vagina or the presenting part. And so sometimes the baby will be partway out, and the cord will prolapse, and you can't continue to deliver that baby. So you have to go for emergency C-section. You can't deliver a single arm breech or a double arm for that matter. I've never seen a double arm. That would be pretty flexible for that baby. But you can't deliver a single arm breech. So again, C-section, emergency. Meconium. So meconium is interesting. We used to have a lot of fear about meconium. If there was any meconium staining, we used to do all this like crazy suctioning and intubation and all this stuff with these kids. Right now, the rule of thumb is if the baby is not vigorous, then we're going to intubate and suction the baby out before we start positive pressure ventilation so that we don't blow any more of that meconium down into the baby's lungs. But they found that meconium aspiration, even if there was a lot of meconium in the amniotic fluid, is actually less prevalent than what they thought. If the baby had ruptured membranes and there was meconium present and you're getting a really poor tracing on the EFM, so if you're getting the external fetal monitoring tracing is poor, so you're getting late D cells or even variable D cells, and the baby is having less and less variability or accelerations in between decelerations, then one of the things we have to think about is, is there enough fluid left over? And is that baby compromised because of the meconium? And so I don't know if you guys remember this, but we talked about an amnio infusion where they stick the catheter in and they can actually kind of replace or kind of backfill some of that amniotic fluid with like a sterile saline, just to kind of fill up that space around the baby and to relieve some of that pressure on the cord. And that also kind of thins out some of that meconium and stuff that the baby is in, and a lot of times that will aid in a better delivery. So an amnio infusion is reserved for times like that where there was a rupture of membranes and now we're getting poor tracings and the baby's really not handling it well. If there's a surgical vaginal delivery, so if we're using like the forceps or the vacuum, just remember that there's a lot of things that can go wrong with that. So there's trauma to mom, obviously, that can go wrong with that. And then there's also trauma to the baby. So for mom, we worry mostly about things like lacerations and hematomas. But for the baby, the baby can have internal head injury and then also can have neck trauma as well, or fractures. So we worry about fractures specifically of the clavicle or the humerus. And so things that you would monitor for then would be abnormal assessment when you're doing your reflex assessment. The baby may have had some sort of trauma to the brachial plexus or to one of the cervical branches during delivery. So just, when you're doing your assessment and you do your reflexes, if you have some sort of a unilateral deficit, that's something that needs to be reported. For postpartum hemorrhage, so remember, you go in and you're going to check mom, and the first thing you do obviously is you notice that there's a boggy uterus, or it's deviated to one side, usually to the right for whatever reason. So the first thing we're going to do is assess the peripad and the perineum, and so that's Rita, right? So we're going to look for any signs of abnormal bleeding or swelling or hematomas or anything at the perineum. And then you're going to have her empty her bladder. And if she can't go, then we're going to straight cath her, right? And then fundal massage, and that occurs until you can feel the uterus, contracting and becoming firmer. And if that's not working, then we move to oxytocin. That is delivered differently postpartum than it is for induction. But, basically the goal is to stimulate contraction and to stop the bleeding. And then with the patient who has preeclampsia or even eclampsia, so preeclampsia is the protein in the urine, the swollen ankles, the headache, the elevated blood pressure, the toxemia of pregnancy essentially. And then pregnancy-induced hypertension kind of go along with preeclampsia. Eclampsia is when you actually have the seizures. The drug of choice is magnesium, and so magnesium is a smooth muscle relaxant, and magnesium will actually stop preterm labor. It'll stop contractions, and also, unfortunately, in the patient who has preeclampsia, will oftentimes stop delivery. And so then it kind of prevents the ability for that person to have vaginal delivery, and they usually have to end up having to go to a C-section. But the problem with eclampsia is that the actual seizure itself, if it occurs, or even just severe hypertension with preeclampsia, can cause an abruptio placenta. So it can actually cause the placenta to tear away from the wall of the uterus. And then again, you get that dark red bleeding. And sometimes because it is irritating the wall of the uterus, patients with placental abruption sometimes do have cramping and pain, especially if it's hidden. So Previa, totally painless, heavy, bright red bleeding, and abruptio placenta tends to be dark red to brown, flowing. And then babies, just two things to keep in mind. Babies would be erythromycin for the eyes and vitamin K shot, because babies can't synthesize vitamin K in the liver, and that puts them at high risk for clotting until about 6 weeks, until they can kind of grow their own. So their liver's immature, which is what happens, with the jaundice, and then also why they need the vitamin K. So any questions about maternal child health? I think if you go back through too, if you have time to go back through and listen to the review for each of the exams that we had in maternal child health, it's all pretty much in there. It's straightforward. There's no there's really no surprises in this section. And so then last but not least is mental health. And
you want to my snowboard?
So mental health is 40 questions.
Let me see.
And some of the meds are a little bit different. So I listed out some of the meds here for you to review. You want to know kind of, what they're used for. Again, if there's any special teaching or like MAOIs, what you would need to know about them, side effects of thorazine or therapeutic ranges of lithium, just kind of the things that we already went over. So in the mental health unit, we talked about how to establish a therapeutic relationship, and we talked a lot about maintaining the therapeutic side of the relationship and trying to set those boundaries and set goals and maintaining safety and prioritizing our care and creating nursing diagnoses. Mental health is a totally different ballgame from other kinds of nursing. It's much less hands-on and much less bedside and much more mental. As far as therapeutic communication, I think we've talked about it a lot, but it's always good just to go back and review what is therapeutic and what's not. And I think you guys are pretty good about knowing how to establish a therapeutic milieu. So again, the goal is to get them in there as much as possible, to not punish whenever you can, to set limits, to encourage them to meet their goals, and to use the reward system as much as possible. As far as defense mechanisms, I would read through those again as well, and make sure that you could match up an action with the defense mechanism. So, projection or repression versus suppression, things like that. Just thinking about those defense mechanisms, like how does the body deal with the anxiety? How does that person cope with the stress that they're under? So we talked about anxiety. And again, I think that there's a pretty good review available to you on most of this. And since we just did it, you don't need as much now. But so anxiety, there's causes physical reaction in the person, and then it stimulates the person to need to take action to minimize that distress, right? So just review the different types of anxiety issues, kind of what we do for it. Review depression, because definitely depression is going to be on there. Schizophrenia and mania. And then the different personality disorders. And the questions on the personality disorders are sometimes about like how could you best talk to the person that has a certain personality disorder, and sometimes they're recognizing certain personality disorders, or like what's the best nursing intervention for different disorders. So if you struggled with the personality disorders on this last exam, go back and review them, because they're different questions, but the personality disorders are still on here. Understand the different somatoform disorders. Okay, and then eating disorders. And the eating disorders are fairly similar as before. So, what's the main root of the problem for anorexia is that they have that morbid fear of obesity. They're obsessed with food. And what's the difference with that in bulimia? Bulimia has the binging and purging versus just the purging that you see with the anorexia. So with the anorexia, severe limited intake and then excessive loss. And with the bulimia, you have severe intake and then purging as well. Both of them, though, are related to anxiety. And, both of them, we want to set healthy goals, realistic goals, and help them come up with coping mechanisms so that they can be successful, in life and in society. We talked about kids and why kids are difficult to diagnose with anything, but it's because normal childhood behavior mimics so many of the mental health issues that we see, and they're just naturally kind of like that. We talked about pretty much all of this. Transference and countertransference, I feel is used kind of strangely on this exam, so just go back and make sure that you understand transference and countertransference, and maybe think of some times that you would need to use proactively plan against it. So like what types of patient populations might elicit the most transference and therefore be at greatest risk of countertransference by the nurse, positive or negative, right? So which ones are going to have the highest impact on you mentally, and how do you plan against that? Like how do you use your team to come up with a plan so that you don't get sucked in, really is the goal. Mental health nursing really is a lot of times about teamwork and not just like, okay, you have this assignment and you're on your own. There's a lot of team planning and teamwork that goes into it. So that's all I had on mental health, unless you guys have any other specific questions. Kind of left you wide open spaces to take notes. Any questions at all? So physical assessment, maternity, or mental health?
Thank you for doing the review.
Oh, no problem. I feel bad that class is canceled. I was like, but then again, I also felt like I couldn't have class if everybody else was canceled. So,
Well, there would. I mean, I didn't have anyone to ring Abby, so that would have been terrible.
Yeah.
And safety first, right?
Right. Well, yeah, exactly. And we have already told the PNs that like if school in Bennington and the surrounding towns get canceled, then we'll cancel class. And then I couldn't like say that we're going to cancel class for the PNs and still have class for the ADNs. Like that would be kind of hypocritical.
Right.
Yeah, it wouldn't be fair.
Well, no. And plus, I mean, you never know. I mean, people would drive far, so I mean, it could get really dangerous.
Yeah, absolutely. And I think I told you guys this in class too, but in a prior year, I had a student who was trying to make it to clinical, and the roads weren't that bad, but where they were coming from, you know, they had to go through this one area where there was a lot of ice, and they got in a car accident on the way to school. And so I just got a text from her husband saying like, you know, she'd been in a car accident, she was in the hospital, and we didn't hear anything for like 4 hours. And it was like the worst day. I was so distracted because all I could think about was like, should I leave clinical and drive to this other hospital where the student was? And, you know, it, you feel so incredibly responsible for you guys when you're out there on the road. Like, even if you're just coming to class, you know, like it's a hard decision to make because, you know, when you're working, you don't get snow days.
Not usually.
No. Right. Like take a school nursing job, I guess, but yeah, not otherwise. So, all right. So I'll post these up there, but I recommend printing off the stuff from the PowerPoint and making sure that you can fill in the blanks or take some notes or something on them. And if you come up with any other questions, just message me. or call me or something. Okay. Tiffany, I can like see the top of your head. Are you good? Do you have any questions? Nope. Okay. Now you turned off your video. Now I can't see you at all.
I didn't know. Can you see me?
Now I can see you.
I didn't know you could see me. I'm sorry. I
No,
thought I
it's-
blocked it out.
It's
I
fine.
guess not.
Are you good?
Good.
Okay. All right, guys. Well, have a lovely afternoon. I'm going to go bake a chicken. Spend all my extra time. All right. Have a great day.
You too. Thanks.
Bye.